Liebe Kolleginnen und Kollegen, liebe Freunde des Amboss Studientelegramms, Marcus at Home welcomes Dr. John Funder at Melbourne, Victoria, with whom we would like to discuss some burning issues in the field of secondary hypertension and particularly primary aldosteronism. So this is our first Marcus at Home talk outside the field of COVID-19 and SARS-CoV-2 vaccinations, and we are really blessed to have Dr. Funder with us. Dr. Funder has done decades of work in the field of adrenal diseases, secondary hypertensions. He had a lot of academic positions, headed several national and international medical societies, had received a lot of academic awards. And just to summarize all this in one word, he's really a legend in the field of secondary hypertension. Thanks, John, for being with us today.
It's a pleasure.
So my co-moderators are Dr. Sarah Morell, who's done some research in the field of adrenal diseases in Würzburg, Germany, in the lab of Dr. Fasnacht, and Anja Scheuer, who's our technical director of Marcus at Home, and who's a medical student at Homburg and Frankfurt. So before coming into the details of hypertension, just one question, John, which is surely of importance to our audience here in Austria and Germany. We would be eager to learn how life is going on in Australia, how you battled COVID-19, and how many restrictions are still out there, because here in Germany and Austria, we still have all this discussion with vaccination and curfews. And the look from the outside looks as if life is much better in Australia presently.
I think that's right. We are an island, which I think is an enormous help. And the borders, the international borders closed very early. We had an initial spike with people coming in who were infected but landed and so on. And then in Victoria, we had a second wave, which came from people who were in quarantine for 14 days, having arrived, returning Australians, but they infected some sort of fairly sloppy security people and so on. And when we had a big second wave with a lot of deaths, I mean, relatively for us, a lot of deaths in Victoria, we still don't have 1,000 people die. It's fewer than 1,000 in a population of 26 million. So in many ways, we have been blessed. The vaccination program is going much more slowly than the government. The government is not my favorite government, but we won't go any further into that, than the government had promised, trumpeted, hoped to see. On the other hand, Victoria, for example, hasn't had a community case for well over a month. So it's very different from what you're going through in Europe, what people are going through in India and Brazil, and even still in America and England. Australia and New Zealand have been, I think, among the most fortunate people in this pandemic. So we had in Victoria more than 100 days of stage 4 lockdown, which was really very difficult for many people, particularly older people. Not me, I have a nice wife, but older people who are on their own. And, they really couldn't have family visits. It was all done by teleconference and Zoom. It was very taxing on a number of people. Also people who couldn't work, or people who had children at school that had to be homeschooled. That actually put to rest the second pandemic in Victoria. So in answer to your question, I've talked a long time, but we've been very lucky, and a combination of, I think, community, going along with what the government wants. It's a bit different from the Wild West of the United States, and luck. We're in a very fortunate position. but I still can't travel over the next 6, probably 9 months to Germany, or I can only go to New Zealand. It's the only place I can go outside Australia. Off.
Okay, I will start with some questions about primary aldosteronism now.
Okay.
And maybe at first for some basic facts. To start off, what's the definition of PA?
I would have thought that primary aldosteronism is inappropriately high aldosterone levels for the sodium status of the individual. Okay, so if you are a Papuan native living on taro, yams and things, and the monsoons come and wash all sodium and everything else out of the soil, the aldosterone levels are sky high, but because the sodium intake's 2 or 3 milliequivalents a day, there's no problem. I mean, that's an aldosterone, a very high aldosterone level, appropriate, physiologically appropriate for the sodium intake. But where the sodium intake is what I'd call normal high, normal Western diet, whatever, and the aldosterone's elevated above what it should be, that's primary aldosteronism. Okay.
Okay. And there are still some controversies about the true prevalence of aldosteronism. What would you say? How common is it really?
I think that we're going to find that it's somewhere between 30, just wait for it, 30 and 80% it is a factor in the blood pressure elevation of so-called essential hypertension. There's no question that essential hypertension can happen, can be in a patient who has absolutely a normal aldosterone sodium system. Okay, I'm not saying it causes all hypertension, it doesn't. But for many years, it's been thought that it's been 5 or 10% of hypertension, a figure which has been, for various reasons, and I can go into them, I think studiously ignored by most cardiologists and hypertension doctors. And now there's increasing evidence, and it's on the basis of the fallibility of measurement, a single spot measurement of aldosterone concentrations. There's increasing evidence that it's much, much more, whether it's 20 or 30 or 50 or 80%. It'll be somewhere in that range, and it won't just be 20. And my bet's on about 50 or 60% of patients with hypertension, at least some part of it. It's possible to be hypertensive and to have primary aldosteronism. They're two different systems. They're two different things wrong. They both have individual and different risk profiles. Okay.
Okay. And what about the underlying diseases? What is the ratio of adenoma versus hyperplasia?
Okay. Currently, it depends on how tough you set the standards for measuring primary aldosteronism. If you have very, what I'd call straitened circumstances, if you're very tough, then you might get 3% of hypertensives that have got an adenoma and 2% of hypertensives who have bilateral adrenal hyperaldosteronism. If you don't have such tough criteria for saying whether or not the patient has primary aldosteronism, a lot of people would say, well, it's maybe 3% have adenoma, because that's the more florid form, usually the more emphasized form, the toughest form, and about 5 or 6% would have bilateral adrenal hyperaldosteronism. So that would take you from the sort of 5% to 10%, which is what's currently put in the textbooks, even though it's often not taken much notice of, despite being in the textbooks. It's going to be a terrible, terrible blow to the hypertension people when it finally dawns on them that half their patients have got primary aldosteronism. But we'll talk about that later.
Okay. Are there any clinical symptoms or any lab results, such as maybe a low potassium or anything that should make us suspect primary aldosteronism?
Sure. If you're hypokalemic on a normal diet, either spontaneously or as the result of being on diuretics, then yes, you must have you must be screened for primary aldosteronism, and the chances of it being there are really very high. If you've got a high salt intake and you're hypertensive, that increases your chances of getting out of the normal feedback loops I talked about of the natives in New Guinea and Papua, who have hardly any sodium during the monsoon system, and their aldosterone goes sky high. So if you've got a family member who's had primary aldosteronism, if you've got sleep apnea, if you've got blood pressure over 140 on 90, in fact, any of those people should be screened for primary aldosteronism. In fact, I think there's probably a good reason for screening every hypertensive for primary aldosteronism. And we'll come back to the fact that about 10% of people who are not hypertensive, even on the criteria of 140 on 90, they may be on 130 on 80, but they still have 10% of them have got primary aldosteronism, too much aldosterone for their sodium status. Okay.
Should every patient with hypertension be tested for or screened for primary aldosteronism?
I think so. And I'll put it into two buckets, two different answers. If when the patient comes to see you or Dr. Harney and you measure the blood pressure and the blood pressure is over whatever you take as the upper limit of normal, and I think many people now are looking at 130 on 80, depending a bit with age, et cetera, then I think those patients, even though they're not very hypertensive, normally what would happen to them is that they'd be read a lecture about salt intake, about stress, about all the other things that might be involved, and then would be put on an antihypertensive and told to come back in a month or 3 months. And I don't think we should do that anymore. I think what we should do, a long way around, in a sense, is to say, okay, I've done 3 measurements, your blood pressure is elevated. What I want to do is to take some blood and measure your plasma renin. And if the plasma renin activity is suppressed, is less than 1, or plasma renin concentration is less than 8 or 15, depending on the assay, then that patient is a candidate for primary aldosteronism. And later on, perhaps we can talk about what do you do with that patient, the naive patient, the newly presenting patient. Mm-hmm. If you've got a patient who's been hypertensive for some years, I think the simplest thing to do for those patients is to put them on an addition to their antihypertensives. And they may be, normotensive if they're not terribly hypertensive and or are being well treated for the hypertension. So, let's say they're 138 on 84, and you wouldn't want to add any more antihypertensives. I would put them on either 25 or 50 milligrams of spironolactone a day for a month and ask them to come back at the end of the month. And if their blood pressure's dropped less than 10 millimeters of mercury systolic, they probably don't have primary aldosteronism, because it's not a bad diuretic anyway, spironolactone. But if they've got primary aldosteronism, the chances are very high that their blood pressure will drop 15 or 12 or 15 or 18 millimeters of mercury with that level, that dose of spironolactone. One of the articles I referenced in the things that Gunnar read was a paper, a fantastic paper done in Cologne in Germany in 1980 by Professor Helber and his colleagues. And they showed that the prevalence of primary aldosteronism is probably about 50% of hypertensives. And they also showed that those who used to be classified as having essential hypertension, but in fact were hypertensive, had a much better response to spironolactone, average blood pressure fall 23 millimeters of mercury, compared with those who did not appear. They were true essential hypertensives, and they had a blood pressure fall of 9 millimeters of mercury. So that's what I would do with people who are currently on antihypertensive medication, et cetera, et cetera. And one of the reasons I would do that is because untreated or even inadequately treated primary aldosteronism has a threefold, at least, higher risk factor than patients who are properly treated. It's on top of the hypertension. I mean, that's an extraordinary risk factor, a combination of risk factors. So even if the blood pressure is very well controlled, it's sensible to see if they've got primary aldosteronism. And then we can take it from there. What happens if they do? What happens if they don't?
So you've started explaining a bit the diagnostic approach. I would like to continue on that field, if that's okay with you. Maybe as a start, can any physician test for primary aldosteronism, or should we send the patient to go to a specialist, that being, for instance, an endocrinologist or a hypertensiologist?
I would answer very emphatically in the affirmative. This, when for reasons I haven't canvassed yet, this has to be in the field of primary care, okay, of what the Americans call PCPs, what the English call general practitioners. It has to be them for two reasons. One is that currently in no country in the world are more than 1% of people with primary aldosteronism ever picked up, ever screened, ever treated. Mm. And the I mean, 30 years, 40 years ago, if I had a hypertensive patient, before all this, came about really, you'd just say, well, let's get your blood pressure down and, that's fine. Well, it's not fine anymore if half those patients have got primary aldosteronism. They're in what in English, I don't know what it is in German, is called double jeopardy. They've got one lot of problems from the hypertension and another lot of problems from the primary aldosteronism. Mm. So this has to be done in general practice. Mm-hmm. And that's why, doing algorithms for, how to do it in general practice, how to get general practitioners to do it, and then whether or not the patients are, for example, if you get a new patient and the patient's got a mildly elevated blood pressure, if you do the plasmarenin and the plasmarenin's normal, not suppressed, that's fine. Then you say, you've got hypertension, it's very unlikely you'll have primary aldosteronism. We're going to fix your hypertension and knock down your salt intake and try and knock down your stress and do all the other good things. Okay. Mm-hmm. So that's, but if the patient has suppressed renin, then my next thing, this is in a naive, a newly presenting patient, my next thing would be to get a 24-hour urine. Mm-hmm. And the reason for wanting a 24-hour urine is that a single spot blood draw in the arm, 10 o'clock in the morning, for aldosterone is absolutely hopeless. People forget that aldosterone is very sensitive to ACTH, So every time you have any sort of stress or, run upstairs or whatever, and your ACTH goes up, your aldosterone goes up.
Mm-hmm.
There's now enormous evidence that doing it on the basis of a single spot, and this is, the screening and the whether or not they've got it, because you give them, something, salt load for 2 hours or 4 hours, that's all wrong. We can't do that anymore, because and the worst thing about it is that probably 4 out of 5 patients who are picked up by a general practitioner or by any doctor and sent to an endocrinologist and undergo screening and, confirmation or not, under the present regime, 4 out of 5 of them are told they don't have primary aldosteronism because the measured aldosterone that they did lying down 2 hours, not thinking about anything except mother, whatever. That's quite wrong. It's hopeless. So GPs are crucial. It has to become part and parcel of how a GP interacts with patients with hypertension. And it'll take 30 years to make this work, and I'll be dead and gone. But you'll still be there, and you still should be doing this.
So if we have a look at the guidelines from 2016 with the aldosterone-renin ratio and the confirmatory tests, the different ones, we should leave that by side. And
that's right.
Okay.
We currently have what's the word? A request. It's more than a request. The endocrine societies agreed to something very unusual, which is a third set of guidelines. Whether or not, they asked me to do why we needed that. I told them why we needed that. Whether or not at this age and stage and distance I'll be involved, I don't know. They haven't actually declared that yet. And it used to be that, if you chaired one lot, you chaired the next lot, and that may happen, but it may not happen. But we need new guidelines. Absolutely new guidelines. And one of the things that no real set of consensus, statements or guidelines have done has paid any attention to the fact that fewer than 1% of hypertensives get screened. And that's our fault. It's the fault of doing that elaborate 4 to 6 weeks off your medication. If your blood pressure goes up, you can have alpha blockers or whatever, et cetera, et cetera, et cetera. We can't do that. It's a total turn-off, both for referring physicians who send people to an endocrinologist or hypertensionologist, but also it's a turn-off for the patients. Oh, doc, you've got my blood pressure down. Why do I have to go through all this shit? Oh, awful.
Okay. What about interfering factors then? Do they no longer play a role? What kind of medication the patient takes, or if he has kidney impairment, or?
Okay. I think, that's usually not a problem for the initially presenting patient.
Okay.
They may have a GFR that's a bit low, depending on their age, et cetera, et cetera, et cetera. But I don't think that's going to be a big problem. For the people who are on established antihypertensives, probably the thing most people are a bit scared of is hypokalemia. If they're already on ACE inhibitors, say, and whatever, and they get a spironolactone or a eplerenone on top, are they going to become and that's got to be watched and got to be looked at. And one of the issues with that is that when people have used spironolactone, they've sometimes used appalling doses of it, which have got side effects and people stop taking it and so on. the ideal thing is to have 25 milligrams of spironolactone, and if you need anything more for the sodium, put them on triamterene or, an ENaC inhibitor, which doesn't have the same problems of compliance. It's been estimated that about 30% of people put on high doses of spironolactone go, no more. No, I can't take it anymore. And that's hopeless. We can't live with that. I think that's the main issue that people are concerned about, and rightly concerned.
So we don't need to pause. If, for instance, the patient has been taking spironolactone already, we don't need to pause it in order to test the plasma renin concentration or activity, or later on the aldosterone in the 24-hour urine.
I don't know.
Okay.
I don't. I mean, I can't give a straight answer. Spironolactone will raise plasma aldosterone concentration, for obvious feedback reasons.
Yeah.
So it is probably sensible, if somebody is on spironolactone, to pause the spironolactone. I'm not sure you need to pause anything else. All the other things that might put it up a bit or down a bit, but pause the spironolactone and then give them 50 milligrams a day. This is a patient with established hypertension. 50 milligrams a day for a month and see what happens to the blood pressure. Yeah.
Okay, perfect.
And you may need a month off spironolactone before you do it.
And sorry. My last question would just be, as nephrologists, we often treat patients with chronic kidney disease, but also treatment-resistant hypertension. And in such cases, if a patient comes to us and we want to exclude secondary causes of hypertension, we often face a problem that regular cutoffs don't really apply because of the impaired kidney function. So how would you proceed in such a case in order to rule out endocrine disorders because of the chronic kidney disease?
Okay. Okay, so they've got chronic kidney disease, they're on medication. Okay.
Yeah.
I don't think there's a problem in a trial of spironolactone in addition to their current medication. These patients are largely hypertensive. And if it brings it down, it brings it down. If it doesn't, it doesn't. Incidentally, one of the questions I saw, I think, on the thing that Gunnar sent was about whatever. It's been made by Bayer, not in fact for primary aldosteronism, or because it is. I think the data are okay. The initial data were very, but it's very much more cardiac focused than renal focused. And it, listening to the people from Bayer, they were very keen not to have something that caused hyperkalemia, but would be effective in the cardiac métier, in the cardiac system. So I think it's not a goer for primary aldosteronism. Spironolactone is a dreadful, dirty drug. It's 60-something years, old. It shouldn't be used at doses preferably of 25 if necessary, or as a test 50. And above that, forget it. Don't do it. You might be able to do it in postmenopausal women and not have much of a problem. You've got to look at but in cycling women, in men up to the age of 70 or 80, you don't want to do it. It's, for erectile dysfunction, etc., it's terrible. Eplerenone is very expensive. I don't know if it is in Germany, but it is in everywhere, I think, except in Japan. It's expensive. A drug I think we should push hard is, now I'll get the words right, Exoceranone, which is Daiichi Sankyo drug. It's extraordinarily potent. you know, the tests that they've used, and they've used it in looking at renal disease, very much so. And if you haven't seen those papers, you should look them up. 1, 2, and 5 milligrams a day. I mean, you know, whoa. It's also incredibly specific, you know, even more than a Eplerenone. The Japanese don't seem to want to go outside Japan with that, and I think that we should try and get them to come outside Japan, because that's really it should be the drug of the future for bilateral adrenal hyperplasia, where you've got to use a mineralocorticoid receptor antagonist anyway.
Thank you.
So this is really a revolution from within, because for all our colleagues who are not aware of this, Dr. Funder is the head of the steering author committee of the former guidelines that used to teach us that we should go for the aldosterone-renin ratio. So it's no better colleague actually than you to tell us to leave this, because this gives credibility to this. But I would just maybe come back to the idea of a confirmatory test, because now you tell us that in the next years we should actually leave the aldosterone-renin ratio. Do you expect any changes in the confirmatory test? So here in Germany we are used to apply the saline infusion test because it's rather simple. I think you have other preferences. Where do you see the future of these tests?
Gunnar, I don't think they're going to live. I think they have no future.
Okay.
And they have no future because they're predicated on a very imperfect way of obtaining the actual patient's actual aldosterone status. You know, it's compounding the fact that if you measure the 24-hour secretion of aldosterone, it's 3 to 5 times higher than what you measure in a single blood draw in the arm. So I think it's yesterday's, you know, both the AR ratio, but also measuring aldosterone, the extent to which, you know, you can put it up or down. What the hell? You know, you're compounding 2 spot levels of aldosterone, and neither of them presumably are much good.
So we would go from the screening test, from the renin levels at baseline, and then directly go to the distinction between adenoma and hyperplasia. That would then be the next step, and we would skip actually the confirmatory test.
I think there are a number of things. I think, again, we've got to distinguish between newly presenting patients and people with established hypertension. And I think people with established hypertension, as Anya and I were talking about, if they've been on spironolactone, they should come off spironolactone for a month. And then I wouldn't do a renin test. Then I'd give them a trial of spironolactone. And if their blood pressure went up over the month they were off spironolactone, and it went right down with spironolactone, that to me is the signal that they have primary aldosteronism, and that's getting rid of the sodium. For newly presenting patients, and we've got to start somewhere with the 99% of people who have primary aldosteronism and are never treated or diagnosed or screened. For newly presenting patients, I think, you know, renin suppression is the key. If somebody's renin suppressed, then do their urinary sodium, potassium, and aldosterone. And if the aldosterone is less than 5 micrograms a day, 6 micrograms a day, they don't have primary aldosteronism, but they probably are eating an enormous amount of salt, you know, to lower their aldosterone to that level. 6 to 12, possible. More than 12, they've got primary aldosteronism. And, you know, there are very good data over the past 12 months that would support bat. And then let's say they've got 12 micrograms a day. Well, then I think it's up to the GP, or the GP may want to send them to a hypertensionologist, an endocrinologist, a nephrologist. But I think a GP could say, all right, the patient's 56, he's male, his blood pressure is not very elevated, his output of aldosterone was 14, not much more than 12. And when we look at his sodium, he doesn't actually have much sodium. We're just going to keep watching him, you know, or maybe try him on some spironolactone. I mean, the best we've got at the moment. But if it's a young woman and she's got a urinary aldosterone ratio that's, you know, not just above normal, and the blood pressure is not just above normal, then I think the GP would be sensible for her or for him to send the patient to a centre of excellence.
Mm-hmm.
The triage must be done because we're talking about getting 99% of people. I mean, there's a saying in English, it's probably the same in German, let not the perfect drive out the good. And what it means is that, you know, you've really got to work for what's going to be easiest and best to get the majority across the line. Okay.
So the problem here in Germany is that our labs are not really prepared to 24-hour urine measurements of aldosterone. They tell us that it's not stable enough for central measurements, but I think we have to rediscuss this with our labs here. So in Australia, it works well, if I got you right.
It works well in Australia. I think it also works well in the States too.
Yeah.
And, you know, I know people who say it's the most difficult assay of the 40 assays we run, you know, et cetera, et cetera, et cetera. But I think it's not all that, it's not rocket science.
Yeah, and we should measure aldosterone itself, no any byproducts or any metabolites. It's aldosterone by itself. Huh?
Metabolites and
Everything,
yeah,
okay.
Everything, yep.
Yeah.
Yep.
Maybe one last question from me with regard to the diagnosis. So we always have the problem, if we are looking for adenomas, to find people who are able to do adrenal venous sampling. And I know this from a variety of different university centers and non-university centers. And the people who are really ready to do this and to do this in a perfect way are very limited. So our own rate of proper investigations is way below 20%. Do you think that there's a future for this, or can we expect any more novel approaches like mutation screening in urine or wheresoever, because we know of all these mutations which may play a role in both adenoma and bilateral hyperplasia?
I think, first up, I mean, adrenal venous sampling is I mean, nothing's perfect, but it's as close as you can get to in experienced hands, the same person doing it, et cetera, et cetera, et cetera. It can be 98 going on 99% correct. Nothing's perfect. But that said, it's an enormous block, because I don't know how much it is in Germany. I know how much it is in America. I know how much it is in Australia. It's thousands and thousands of dollars or thousands of euros. For many patients, it's a block. But if we're looking at increasing the number of people that we think have primary aldosteronism and want to lateralize, it's a cost that the health systems are really not going to be happy about. That said, there are a number of things. There are fluorine derivatives that of various. Merck had a drug which they let out, didn't use for as a aldosterone synthase inhibitor. I think it's called something B2234 or something like that. I can find it for you afterwards. And that's really very much better than metomidate at localizing, adenomas. And it's going to be much cheaper than metomidate, particularly because you don't need a cyclotron to make it. I think that there are ways in which we can limit the use of AVS, and there'll be a group of patients that are extraordinarily likely to have AVS, and there are a group that will be extraordinarily unlikely to have AVS, and there'll be a group in the middle where AVS for a while at least will need to be used. There's a paper in, it's not in press yet, but looks at a very large cohort of people from around the world, aged 45 to 41, 40 to 36, 35 and lower. And post hoc, because all these people had AVS and all had imaging, it's not perfect, but it's a very good way of validating the very rare occurrence of taking the wrong adrenal out. That's the danger, taking the wrong adrenal out. It doesn't matter if the other adrenal is actually working a bit, if you take out the adenoma, but and so on. There are also, I think, ways in which, for instance, certainly in Japan and China, where the prevalence of KCNJ5 mutations is very high, the level of, what would I call it, hydroxylated cortisol derivatives, because the KCNJ5 mutations are in the normal cortisol producing cells, not in aldosterone producing cells. Levels of those in the plasma, if they're high, that's very indicative of a KCNJ5 producing tumor. It would be not an excuse, but an indication for really having a look. I think that it may even come to radio frequency ablation under guidance of the tumor, leaving enough cells in the adrenal not to be affected, and then watching what happens. I mean, we've got to get different ways than spending between $11,000 and $20,000 per patient on this. It's not going to work. And I go back to let not the perfect drive out the good. If we have somebody that we're not sure if they've got an adenoma or a bilateral disease, they're not going to do very badly on, a well-managed regime of antihypertensive, sure, but also of mineralocorticoid receptor antagonists and measurements of plasma renin at 6 months to show that they're not renin suppressed. If they're renin suppressed, their aldosterone is still too high. Unless they're on a salt-free diet. So I think there are going to be ways around it. There currently are, I think, ways to not minimize is too strong a term, but to get AVS concentrated in the people that we really aren't sure, or we're never going to be sure, we really don't think have a tumor, or we really think do have a tumor. But it's a problem, and I sympathize with you. But to do adrenalectomies on the basis of a tumor on one side and a normal renal on the other side is very age dependent, very age And, you'll probably get away with it under 40 or 45 most of the time, but you won't get away with it, in 50, 55, 60. Yeah.
So you give us a lot of work to convince our colleagues that we had to shift our gears now again, because we did quite a lot of teaching in the last years, explaining everybody that we should go for the aldosterone-renin ratio. Maybe just before I shift the mic again to Anya for the last questions on the treatment, we have some slides integrated into this discussion which give all the suggestions by Dr. Funder. We always have to take into account that measurements of renin are sometimes given as units, sometimes as milligrams, sometimes as activity. So I think in Australia, it's rather the units or the activity, while we here in Germany have the milligrams. So just for our audience to look at these slides, just always keep this in mind, and you have to do the conversation.
Yeah. We have either PRA or PRC, either activity or concentration, yes. Yeah.
Okay, so you already commented a lot on therapy, so I won't go into depth, but you said that there are different treatment options depending on the origin of the primary aldosteronism surgery versus spironolactone. You talked about the dosing of spironolactone, and you talked about the role of other aldosterone blockers, such as eplerenone and finerenone, which the latter you said played no role really in that disease.
Well, yes.
Okay.
It was designed not to play a role.
Yeah.
To be tubule sparing. Yeah.
And you also said that primary aldosteronism was associated with a number of comorbidities or a number of complications that come on top of the complications that the patient already has because of the hypertension. So my question is, once you do diagnose the primary aldosteronism and you treat it, is there any chance of reversing those complications, or is it just a matter of lowering the risk from that point on?
No. I mean, the good news is that if you appropriately treat bilateral adrenal hyperaldosteronism, who don't have an adenoma, if you treat them so that their renin is no longer suppressed, then they have no more comorbidities, than essential hypertensives with the same blood pressure. But if you don't, and their renin is suppressed, then they're 3 times higher. And the problem, particularly, is the people who are never sort of screened or treated or never get near. And if they've got primary aldosteronism, they're 3 times higher than people with the same blood pressure who don't have it. So yes, it's not, fixed in tablets of stone. If you can get the aldosterone down to normal levels, so it's not suppressing renin by getting rid of sodium, then your risk profile comes back to normal. The interesting thing is that the risk profile for treated patients treated surgically is actually slightly but significantly better than that for age, sex, and blood pressure matched essential hypertensives. That's fine. It may be that the age, sex, and blood pressure matched essential hypertensives actually have a cohort of occult primary aldosterone within them, so that they're not truly only essential hypertensive. But the good news is that if you treat bilateral disease vigorously, appropriately, then the risk factor comes down to nothing.
I see. Thank you. So my last question would be, what is the key information that you would like our viewers to remember about primary aldosteronism?
I'd like them to reflect on and to remember that aldosterone is a hormone which is not just responsive to renin, It's also responsive, and people more or less take this into account to potassium status. But it's also exquisitely responsive, albeit not long term, again and again and again, yes, to ACTH. And it's probably responsive to a number of other things, leptin for one, and so on and so on. So we ignore the physiology of aldosterone at our peril, and ignoring the physiology of aldosterone is what has actually lulled me and the field into believing that a single blood draw for aldosterone tells you all you need to know about aldosterone in that patient. And when you look at what actually over the course of 24 hours is secreted, and the best way to get that is in the urinary excretion, then the actual level of aldosterone in those patients is commonly 3 to 5 times higher. That's the thing that really rubs out the first part of the Guidelines 2008, the Guidelines 2016. That part is no longer correct. What is correct is doing imaging, doing the AVS if you can, etc., being careful if you can't, and so on and so on. I mean, the rest of it's fine, but the screening and the confirmatory stuff are both predicated on very fallible ways of measuring aldosterone, and we ignore physiology at our peril. That's what I would say to you.
So thanks a lot. This was really fascinating talking to you, and we're looking forward to reading the 2023 or 2024 maybe recommendations. Hopefully they will invite you to chair the committee, because again, I think if it gives much more credibility to these things if it stays with the same people who really got all the differences and the novel information integrated. We are not looking forward to discussing the cost issues with our general physicians if we advise them to screen in every people. So I'm kind of afraid. Yeah?
I'd take them gently. I'd take them when you've got a newly presenting patient, do this.
Yeah.
And get them involved.
Yeah.
Softly, catchy monkey.
Okay.
Old Chinese proverb. I think that the first thing we've got to do, I mean, for the Americans, for instance, is the Annals of Internal Medicine, which goes out to the general practitioners, primary care. We've got to sell them on when a new patient comes in, this is your chance.
Yeah, okay. So we will refer to our video anyway, so they can follow the recommendation from the leading expert, actually. So this gives even more credibility to this. So thanks a lot, John. We will have other discussions in the field next Wednesday, so Wednesday 28th, with a YouTube discussion live from Frankfurt, where we will again go back into secondary hypertension in German, then that term, and have a nice evening in Melbourne. We have to go back to our work now, unfortunately, because we are 8 hours behind you. But looking forward to meeting you maybe one day when you are allowed to come to us, or maybe even one day in Australia for us. So thanks, John.
And thank you, ladies, too. Okay.
Thank you.
Thank you.